Good evening, everybody. I'm Louis Cabani. I'm the program director for the Vascular Surgery Fellowship at Henry Ford Hospital. My co-moderator is Ashley Giffen. You want to introduce yourself, Ashley?
Hi, my name is Ashley Gutwein. I'm one of the vascular surgery staff at Indiana University. Welcome tonight and thank you for your evening.
Yeah, we have a very nice panelist. We're talking about introducing you to vascular surgery as a career choice for medical students who are interested in vascular surgery. I'd like to remind everybody that our meeting is in September, and we have a whole session for medical students with hands-on experience doing endo and open. And we have mentors that are interested in guiding you through the conference if you're interested. So if you want to join us at the Midwest Vascular Society Conference in Chicago, Angela will help you do that. And I think there is a registration for that. Hope to see you there. We're going to start our session with Jason Cook from the University of Nebraska. He's going to talk about what exactly is vascular surgery. Jason?
Hello and welcome. I'm Jason Cook. I'm one of the staff at University of Nebraska, and I'm going to try to start us off with really trying to give you guys a quick overview in 10 minutes or so of what it is that we do. I think the way to define what we do is to say, who are we? You know, our specialty is defined as having expertise in the diagnosis and management of any arterial, venous, and or lymphatic system, excluding the brain and the heart itself. And so we have, experience providing both comprehensive care, longitudinal care to patients with all sorts of vascular diseases. But I think what makes us a unique group is that we also do the medical management in addition to the surgical treatment. And so we're sort of your one-stop shop that can offer everything to patients. So to give you a really brief overview of what do we treat, I put a couple of things on here. So carotid endarterectomy is carotid atherosclerotic disease, and we can do these through open incisions or more minimally invasive TCAR, open and endovascular aneurysms, open or endovascular bypasses for legs, and this can be for aneurysms or peripheral arterial disease. But in addition to, just basic reconstructive disease, we also do a lot of wound care. So diabetic foot wounds comprises a large proportion of our practice and provides us longitudinal care for patients. But in addition to arterial disease, this is a patient with phlegmasia with venous disease. So we also do venous disorders, including both superficial and deep venous thrombosis. Varicose veins is another, subtype of venous disorders that we also see. And then, the combination of arterial and venous disease, and this is an arterial venous fistula done for a dialysis access. And so this is not the most attractive one, but something else that we do quite frequently. And then lastly, I just sort of put up here, extra anatomic bypass. This is a patient with an infrarenal aortic occlusion with bilateral axis-femoral artery bypasses. And so effectively, we can reroute plumbing anywhere, both in the arterial system and venous. And I don't know if anybody knows this guy. I'm from New York, not that I'm a Mets fan for all of you, unfortunately, but this was a overhead athlete, and he developed venous thoracic outlet, and I didn't do his case, but I put on here the other type of venous disease we do. I came from Washington University in St. Louis, where Catherine is, and so venous disease, both of the deep and the superficial system of the legs, but also of the arm. And so this is one of our patients with extrinsic compression on the subclavian vein. When you take the rib out, you can actually restore circulation and prevent them from getting recurrent disease. And this is a very fulfilling thing for patients, particularly because they're younger and it really impacts their long-term care. But in addition to the stuff we've talked about, we are also, quite important from a hospital setting, because one of the things that Ben Starnes and his group published is we're becoming more and more necessary. So unfortunately, from 2002 to 2017, there's been over a 500% increase in intraoperative consultation. And these can be from anything from hemorrhage to extremity malperfusion, arterial injury. At the end of the day, we're there to help our fellow surgeons. And so I think the important thing is, what do we really do? We're sort of the firefighters, and we're called all the time for different types of cases. Hey, we got bleeding in, OR 10. Can you quickly go and help? And sometimes it's as easy as throwing a stitch in it. But at the end of the day, we're the ones who a lot of other surgeons will call to help. So, long-term, we have great job security. Where do we treat patients? So, you can develop a practice that is really clinic-based, both for, outpatient surgery in terms of clinic procedures, venous disorders, et cetera, but open surgery versus endovascular surgery as well. So a lot of places are tied to both, larger, institutions with larger ORs, but you can have an endovascular surgical suite at an outpatient surgical center as well. And so, you can do both private practice or academics or anything in between. And then I was very quickly going to run through 3 different types of topics. So carotid disease, the traditional carotid endarterectomy is a longitudinal incision or an oblique incision in the neck. Identification of very nice anatomy, very similar to your textbook. First done in 1965 with open carotid endarterectomy with patch angioplasty, evolved in the 80s with transfemoral stenting. So here you see a carotid angiogram with an internal carotid artery stenosis treated with a stent. And this was great. This can be done through someone's groin. Although with our peripheral arterial patients, sometimes we can't always get there from the groin. And so transcarotid arterial revascularization came out in 2011, and this was more of a minimally invasive small incision on the neck and then venous access percutaneously in the groin. And this has really changed some of what we do. And so right now we still practice all 3 of these, at least at our center and at most big academic centers as well, that, we can sort of provide the spectrum of treatment. So a lot of what we do is open or endovascular, or again, we can do the hybrid approach. Same goes for aneurysm. So suprarenal, pararenal, juxtarenal, and infrarenal. We can do these with open or endovascular techniques. Open techniques have been around forever. Endovascular techniques continue to evolve. And these can be branched graft chimneys and effectively anything you can imagine you can do. And, to that end, you can do open surgery just with mesenteric bypasses and then end up putting grafts in to effectively create hybrid approaches to repair people. And I think one of the beauties of what we can do is, effectively we can replace someone's aorta, more or less from the heart down to the groins. And these are some of the most attractive exposures we do. They take quite a while, but it's a beautiful exposure of the thoracoabdominal aneurysm. And so, these are big incisions going through the retroperitoneum where you can replace the paravisceral aorta. This was one of my patients with a thoracoabdominal aneurysm, and just to show, the pathology from the left subclavian down with a type E dissection with an interposition proximal portion with an open thoracoabdominal approach. The guy was unfortunately in the hospital for about a month, and then we brought him back to do his distal. He was in the hospital for 3 days, done percutaneously with stent grafts. And so it's the beauty of being able to offer everything to the patients and be their single point of contact. Peripheral arterial disease is very similar. We can do open versus endovascular. So on the top right here, you can see an endovascular procedure. This is a same-day surgery. And depending on what the anatomy is, sometimes it's amenable, sometimes it's not. Sometimes you have to do an open bypass shown here in the bottom left. But again, you're the one making that decision. It's your interaction with the patient and your longitudinal care. And patients really appreciate that. And I think one of the big benefits for us is because we can offer everything, we can really offer the patients the right answer. So, what is vascular surgery? If you take anything away from this, we're plumbers, right? At the end of the day, we do plumbing. We can reroute the plumbing. We can unclog the plumbing. We have all sorts of cool tricks and devices. But I think, the importance of what we do is that we can do arterial and venous disorders, medical management, minimally invasive, open endovascular, and combinations of them. In addition, we're really a surgical subspecialty that supports our fellow surgeons and interventionalists. It's very hard for a lot of interventionalists to fix their own problems because it requires an incision. And because we can do a lot of that kind of stuff in terms of repairing blood vessels, we can actually help them. And I think lastly, vascular surgery is an opportunity to develop really long-term relationships with our patients. And I think the patients genuinely enjoy coming to see us. I'd say we do have both a positive effect on people, and sometimes we get people to do things like stop smoking. But otherwise, because it's a long-term relationship, they really see you just like they see their primary care providers. So thank you.
Thank you for that, Jason. We'll save some time for discussions and questions at the end. So we'll move on to our next presentation, which is going to be from Catherine from WashU University in St. Louis, and she'll be giving a presentation on how to make an impression on a vascular surgery rotation.
All right, hopefully everyone is seeing the right thing at this point in time. So I'm pleased to be here giving this talk because I feel like I've been honing it for many years now, because I never intended to do a vascular rotation, and yet here I am today somehow. So I think before starting about what you can do to make an impression, you need to actually know who you're making a good impression on. And so, vascular attendings are, obvious, OR personnel. You're going to primarily be engaging with these individuals and demonstrating your competency in the OR, but you also may interact with attendings in clinic. You're also going to be making impressions on the vascular trainees and the APPs on the team, and that typically is going to be your participation on the floor and on rounds. And so it's good to know that you have to consider all these individuals because any one of these people could potentially sink your prospects for a vascular surgery career. So on rounds, you are expected to present on patients even though rounds move fast. We understand that's part of your education. But before presenting on patients, it's a good idea to discuss with a chief or fellow and figure out what format they would prefer. Be brief. If you need overnight events, it's good to talk to the covering intern or nurse and have a plan. And so I encourage you to get a template, something like this, where you can, kind of write out the things that are important, your one-liner, events overnight, a physical exam, including critical vitals, as well as usually pulse exam, any sort of testing or imaging results, as well as your plan, which is going to be your one-liner, and then typically a list of your plan, in essentially relative order of importance, because no one's got time for a system-based approach. You may need to ask your rounding team, that is your chief or fellow, if you can present on rounds, and then you also may need to remind them when you get to that particular patient's door that you are planning to present on those patients, because it's easy to forget. You should anticipate needs on rounds, and this is a lot related to like the dressing and supplies that a patient needs. If you're permitted to, taking down dressings when pre-rounding can be a great way to know what patients need. You want to have dressing supplies and Doppler box at the ready, and the better you know all the patients, the better stocked your dressing supply bag or cart can be. If there is not a communal dressing supply bag or cart, I would consider building your own and bringing on rounds. And carry trauma shears. You can't know how valuable those are when you're trying to cut off the dressing that was wrapped and taped aggressively by a nurse. If you really want to shine on rounds, know your patient list well. You can have specific dressing supplies, like stack of little ones ready, already pulled before you even walk in the patient's room, and that's going to make you look really slick. Learn how to check pulses or signals. So the dorsalis pedis artery is just lateral to the first tendon on the foot, so the extensor hallucis longus tendon, and then the posterior tibial artery runs just behind the medial malleolus. Just from a nomenclature standpoint, you cannot palpate a signal, you can palpate a pulse, and you can Doppler a signal in the operating room. So the 3 A's, they'll be a starting point, but they can go a long way. I would say introduce yourself to the patient in pre-op, introduce yourself to the circulator and scrub in the OR so that they know who's going to be working around them. Understand that the rules of the operating room can vary, and that can be dependent upon scrub nurse, that can be dependent on specialty or institution. I would say don't grab off the Mayo as a rule unless you're told it's okay explicitly, and demonstrate your respect for sterility. There is nothing that makes an OR team more anxious than a med student that walks in and immediately contaminates themselves or the field. And be part of the F1 pit crew. When you bring the patient into the operating room, there's going to be a lot of things that need to happen in order to get that patient ready for getting their operation. You can help move the patient in the bed. You can potentially place the Foley, shave the patient, check and mark signals, all these things. If you do them, it demonstrates to the team that you have a sense of what's going on overall, and that you can figure out where you can be helpful in that. Practice your basic skills, practice ties. Pretty much anyone can give you some ties to practice on. And when anesthesia is messing around, you can be tying on your waistband. Learn a running skin closure. That's primarily what you're going to be permitted to do, and pass instruments and ties correctly. Now, say you've got the mets in your hand ready to go to cut some suture, and then you realize you can't see, and then you pass it, you know, willy-nilly over to the fellow, and then the fellow has to turn, look at the instrument, readjust it, and then can go back to the operation, which is a lot different than, you know, scrub handing into your hand and being able to then immediately go to the operation without even having to look away. So, you know, practice that. Hand out, handle and palm, hand out, handle and palm. And ties, you should have someone show you how to practice them. Be interested and engaged. Demonstrate your competence by anticipating the needs and understanding where the operation is happening. You have to, basic example is having scissors in your hands when someone's tying. But, you know, suction where the surgeon needs to see, that's critical too. You know, you might have the whole belly open, but the operation at a given time might just be like right at the left renal artery. So you need to be suctioning appropriately in a time that works for the surgeon to be able to see what's going on. You can have your bovie ready when the surgeons are asking for their pickups to be burned or tapped, and take cues from the scrub. They may actually be trying to help you by handing you the next instrument you need. Pimping, mostly not a thing, but you may be asked questions. Just don't freeze or BS. You aren't expected to get every question right. And don't be fearful of asking questions, but ask good questions. And I don't mean that any question is a bad question. I just mean that there are some questions that can make you look like you are clueless and haven't done any research into the topic. And there are ones that can make it seem like you understand what the operation is and what about the patient, but that you need more detail on some specific thing. There are basic tools that you should get used to. Your DeBakey forceps and your Gerald forceps differ by the teeth, not by the overall shape of the instrument. And you'll be using the suctions and the rubber shods pretty constantly. For endovascular tools, knowing just basic things like a 4-French sheath is red, a 6-French sheath is green. Those are good starter ones, and the catheters vary based on their shape. And knowing that a sheath is measured by the inner diameter and a catheter is measured by the outer diameter, meaning a 4-French MPA can go through a 4-French sheath. So there are other opportunities that you can use to kind of show off on your rotation as well. And one of those ways is going to clinic. And if you go to clinic, you should prep for clinic. That means you look up the patients, you review relevant imaging, you read up on diagnoses if you're unfamiliar with what was going to be covered. If you're permitted to see patients on your own, that's great. This is likely the only time you're going to be presenting patients directly to an attending. And brevity is even more important when presenting to an attending. So start with the key problem that the patient has and build your presentation around that. You know, patient is a 66-year-old male who presents for evaluation of PAD. He has short distance claudication after 1/4 block or up half a flight of stairs. And, you know, he has ABIs of 0.5, 0.6, monophasic signals throughout. And I think that we should recommend a walking program, starting the trial of cilostazol and seeing the patient back in 3 weeks. So you can be brief, you just have to focus on the problem and have kind of the other stuff in your pocket if the attending asks. Your one-liner should include things that change management, like barriers to putting the patient through additional testing or an operation. So this, I mean, you know, something that is a severe cardiopulmonary problem, chronic kidney disease, and knowing the creatinine, or conditions that require anticoagulation. Oftentimes at the end of the rotation, you might have to do a presentation that is typically a case presentation, but I would recommend discussing that with a chief or fellow ahead of time. They know what topics students present on constantly and what topics are more interesting for the group. For example, we are a TOS center and we get a TOS presentation about every 2 to 3 months from a student, and immediately everyone checks out. Review the case plan with a chief or fellow and go over potential alternatives, because this is a huge opportunity for you to demonstrate your mastery of that subject and that operation, and will be kind of interesting to attendees. I would say this is very general guidance, definitely not universal, but I would say focus about 3/4 on the patient and case and 1/4 about the relevant literature. If you're only spending a couple of slides on the patient and case, then you're probably not going to hold people's attention too well. Though we did have a presentation recently that was entirely on literature and was excellent. So entirely not universal. So otherwise, have fun, good luck, and I hope you enjoy your rotations.
Catherine, that was really awesome. I don't know if, but I was writing some notes to give out to my medical students when they join my rotation from your talk. Really, really nice. Thank you. Next, we're gonna have which vascular surgery training pathway is right for me by Ashley Gedman, Indiana University School of Medicine. Ashley?
Hi, everyone. Welcome. And I'm going to be going over which vascular surgery training pathway is right for you, mainly trying to go over the difference between the integrated residency versus doing a traditional fellowship. So some disclosures, I am trained from an integrated vascular surgery residency, but I do currently train both integrated and traditional fellows. So I'm exposed to both of them daily. So I think I'm a fairly unbiased opinion. So when we think about the two different options, everybody has to go through 4 years of college and then 4 years of medical school. At that point, that's where you can kind of have the option to differentiate yourself of whether you're going to go to general surgery first or go to the vascular surgery residency.
Ashley, do you have slides by any chance or no? Because we still,
Yeah, it says it's sharing. Is it not sharing?
no, we still have Kathy's slides.
Okay, let me stop sharing and then I'll reshare. Okay, I stopped sharing and
Can you
then
stop sharing?
and then
Wilson, can you stop sharing?
I can see your slides.
Good, thank
can you
you.
see can you see my slides now?
Yep, you can see the slides.
Okay, sorry. So the two training pathways, 4 years of college, 4 years of medical school are kind of the guarantee. And that's when you have the chance to differentiate yourself of whether you're going to do general surgery or do integrated vascular. Generally speaking, general surgery is 5 years plus or minus 1 to 2 years of research, followed then by a 2-year vascular surgery fellowship. The alternative would be coming out of medical school saying, hey, I know that vascular surgery is right for me, and I want to go into vascular surgery. Most of the programs are 5 years clinical, and then depending on where you go, it's either going to be 1 or 2 years of research or 0 years of research, just kind of depending on which program you choose. So the integrated is a little bit more efficient, but the general surgery has a little bit more options kind of once you start the general surgery pathway of what you want to do. At the end of the day, if you go through the traditional general surgery residency into the fellowship, you can get boarded first in general surgery and then vascular surgery boarded. So you can technically practice both general surgery and vascular surgery. I think the one caveat to that is most people at this point, if they do vascular surgery, I would say 95+% of people don't usually use their general surgery boards. There are a few people that I know have gone back to more rural places where they do get in the general surgery call pool and do a little bit of general surgery as well, but that's not the traditional kind of what I would see 95% of people doing. If you do vascular surgery, you're just going to be boarded in vascular surgery, obviously. When we look at your training pathways and what rotations you'll do, basically, if you go through the integrated pathway, the first 3 years or 4 years, depending on exactly which program you go through, is usually a mixture of general surgery, a little bit of trauma, potentially interventional radiology, critical care, things that give you kind of the how to be a doctor rotations is what we describe them. And then usually your last 2 years are more full-fledged vascular surgery. And that's kind of in line with what the traditional fellowship is, being 2 full years at the end of full vascular surgery. So this is kind of just our kind of block schedule for the year, showing our rotations. At the end of the day, if we look at what ACGME kind of requires you to do, if you're an integrated resident, you have to have 18 months of what we consider core surgical education experience. That can be general surgery, cardiothoracic surgery, crit care, urology, plastics, burn, trauma, things along those lines, with the idea that 30 months then has to be completely vascular surgery. And if we compare that to what the traditional fellowship has, traditional fellowship is going to be 24 months, obviously, of vascular surgery experience. But at the end of the day, they have the same relative case volumes. You're going to need to have 250 major vascular reconstructive procedures, for either pathway, and you need 500 total major operations if you're integrated, with the idea that at the end, you are also need to be responsible the final year of a vascular surgery service as the primary person. So at the end of the day, they have similar requirements through ACGME. It's just a matter of how you get there. But at the end of the day, they're very similar. So if we look at kind of some of the publications to say, hey, which one's better? Who is going to be a better surgeon at the end of the day? There's been lots of people that have looked into this. The integrated vascular surgery residency is new over the last 10 to 15 years. So it's something that people were very interested in. And if we look at kind of comparing case volumes, if we think of case volumes of being experienced and experience equal quality of surgeon, really, if you look at it, you would expect that the 5+2s does have a total number of major operations, which is true, because they have 2 more years of operative experience, typically speaking. But if we look at the vascular surgery cases, your integrated residencies tend to have higher volumes of vascular surgery cases, and that's kind of makes sense with 30 months of required vascular surgery. And then if you look at kind of breaking it down further, once again, there's not a big difference in the number of case volumes compared to the 5+2 plus 0+5. So that kind of makes us think, hey, probably an equal product if we look at case volumes equals experience equals quality of surgical outcomes. The one place that you will see the major difference, which is as you'd expect, is the number of biliary, small intestine, and large intestine surgeries. This is probably the one area where people kind of get nervous with the integrated residencies, is how comfortable are they with medicine in general, and how comfortable are they in a belly? And this is the one area where I think people will sometimes debate, but I don't think they have a lot of evidence to say that truly the fellowship is going to give you a better outcome. One other major difference between the two of them is, generally speaking, the integrated residencies have potentially dedicated research time. Depending on which one you're planning on going through, you can get 1 or 2 years of dedicated research. And then if you're going through the general surgery program, you don't have to do research necessarily to match into the vascular surgery program, so you can be more clinically oriented. So if you had my gestalt of how I kind of view my residents and fellows, the first year resident is generally a little bit more endovascular savvy. They've been doing this for a little bit longer. They're a little more comfortable with wires and catheters. They also are very familiar with the system and the staff, so they have a little bit easier transition into that 4th and 5th year, where your fellow has now had 5 years, is boarded in general surgery, has a little bit more surgical swagger. But at the end of the day, quite honestly, I can't tell the difference between the two of them. I think at the end of the day, you are pretty much an equal product, depending that you go through a program that has sufficient open and endovascular experience. Is kind of my gestalt on it. And I think you could probably pick the brains of everybody here and ask their opinion, but that's the general consensus, I think, within the community right now. So if we look into some of the statistics of what does it take to get into a residency versus a fellowship, from 2024, there was 100 spots for the integrated residency. That's within 79 programs. So most of these are one spot, one resident per year, with the idea about 81% of MDs and 24% matched DOs within the United States. Looking at fellowship, it's becoming a little bit more competitive as time goes on. You can see the trend from 2020 to 2024. There's been an increase in number of applicants from 130 to the 180, and then back down to 155, with the idea that potentially fellowship is getting a little bit more competitive. And then kind of looking at what if you're going through the graduating seniors, what is their scores and their credentials to become a vascular surgery fellowship. Looking through this, this is kind of the mean numbers that they're going to give you. And the probability of matching obviously goes up with the number of programs that you rank and the number of research presentations that you give. So I think my main take-home points are, if you aren't sure what you want to do, it is always safe to do general surgery, because at the end of the day, you can always do a vascular fellowship and no education is truly wasted. So I think if you said, hey, I don't really know exactly what I want to do. General surgery is always a very, very safe route. But I think in this era, we would say that you're generally equal end products if you do decide to go through an integrated route. Right now, the integrated residencies are slightly more competitive, but fellowship is becoming more competitive as the years go on. And then the question of what is the role of having that second general surgery boards versus having just vascular surgery boards if you want to practice somewhere more rural or have a little bit broader of a practice. So those are my points for you today, and thank you for your time.
Ashley, that was great. A lot of good points. And like Ashley said, if you don't know what you want, general surgery is probably a good thing. But if you know what you want, there's really no reason why you should do a vascular surgery residency. So really, that training is very similar, and we have a 2 and 5 that is awesome. We're very happy with the product. Next, we have Abby Rosenthine, how to find a mentor and get what you need from them from Medical College of Wisconsin. Abby?
Let me just share my screen. Can everybody see my slides? All right. So as Dr. Kapani said, I'm Abby Rosen, and I'm one of the faculty at Medical College of Wisconsin in Milwaukee. And I'm going to talk a little bit about how to find a mentor and get what you need from them. I have no relevant disclosures for this topic, other than, I've used a lot of mentors. We all have. I mean, you don't get to, even for you guys, where you are in medical school without having mentors that have helped you along the way. And I came across this as I was putting together this talk and thought it was really funny. It's mentoring is not just about people putting out people that are just like them. It's really about helping people kind of achieve their goals and things like that. And you don't just become a mentor. People develop into mentors. People have to have good qualities to be good mentors. And that's what we're going to talk a little bit about over the next 5 minutes or so, 5-10 minutes. So, again, mentoring can look very different for a lot of different people. Some people are looking for a mentor to help provide them with direction. Other people have very specific goals and want to have certain successes and want to get plugged in with people who are going to help them with that. Other people are looking more for somebody to support them, somebody who can give them advice, someone who they can talk to. Other people are looking for very specific training. And so you're going to have different mentors. One mentor is not going to wear every single, one of these hats. So we talk about having multiple different mentors, each maybe wearing a little bit of different hats. So, for me, when I was kind of coming through medical school residency, I had certain people that I met that I went to for career advice, whether that was a surgeon who I worked with, on my rotation, somebody who I maybe was looking for a letter of recommendation, or even a senior resident. Maybe then as you move into your residency and work into, looking for a job and things like that, or even as a medical student, finding someone who's going to be a facilitator and help introduce you to people. This is something that I think MVSS does great about. If for those of you who have never been to our meeting, I'd highly encourage you guys to come. Vascular surgery is an extremely tight-knit, close-knit society. We all, especially in the Midwest, most of us know each other, or we get to know each other. Everyone's very friendly. And it's nothing for me to take a student with me to a meeting and say, hey, let me introduce you around. And that's a great way to make connections and find people who are maybe not even at your institution that you can have mentorship virtually. And then there's role models. Who do you work with that you emulate and you look up to them professionally and things like that? They may be a good mentor. As I said before, maybe there's somebody who has a specific training that you want to get. Maybe you have an interest in thoracic outlet or venous insufficiency or things like that. And you're going to someone who, specifically has that knowledge base and can help you get, augment that part of your practice or get better at that. Sometimes you just need a cheerleader or a confidant. You need someone who you can sit to and talk about, how was your day? I had a really rough call. I did XYZ. I apologize. My 2-year-old's trying to break into my office. And then personal mentors, I am a a female surgeon, I am a mom, and it's nice to find mentors within that specific realm. Maybe it's something, with regard to socioeconomic status, ethnicity, location, where you're from. So there are different people that can help you through different aspects, of being a mentor. So what do you look for? Who makes a good mentor? We already mentioned a little bit about the 3 A's, being available. Somebody has to have time to do this, to sit down and meet with you, whether it's over a cup of coffee or a casual lunch or over Zoom or over a cocktail or something like that. Somebody has to make time to do that. And you want someone who's going to do that. Somebody who is affable, somebody who is respectful, somebody who's enthusiastic to be a mentor. In general, people who volunteer to participate in mentor programs, from a faculty side of things, are going to be enthusiastic about it, but whether they have the other two characteristics is something that you have to kind of decide. And then, are they able? Do they have the knowledge base? Do they have the skill set to get you to where you want to be? Do they have the connections to do that? And are they able to do that in a respectful manner, and things like that? And I guess you could say amazing would be the 4th A, but I think availability is the most important thing, followed by the affability, and then the ability being kind of the last quality that I think of with regard to being a good mentor. Then when we have a good mentor for you guys, how can you be a good mentee? So the first part I would say is come prepared, be prepared. Know what you're asking for, understand what goals you have. What type of mentor are you asking them to be? Setting the expectations for that, so that everyone is clear on what the roles and what the expectations are. Because I think that's the mentor-mentee relationships I've seen that have struggled are ones where there is some kind of miscommunication, or the mentor thinks that, well, I'm just meeting with them, but the mentee is asking for very specific things. So just making sure you're setting those expectations and things like that. Being very humble, being open, leave the ego at the door, be very self-aware. And with that, be reflective and open to constructive criticism and things like that. And try not to be defensive. If you're asking someone to be very honest with you and give you good constructive feedback, you have to be willing to receive it and make changes if necessary. The other one thing that I can say that is, a really easy thing to be very good at or bad is communicate. So sending an email, sending a follow-up email, making sure you get a meeting on the calendar, be on time, and I think that's the one thing that as a medical student, sometimes people will say, oh, it's just answering an email, but just staying on top of that is absolutely huge. So being a good communicator, and I always over communicate more than less. And then understand that mentorships can change, and that's okay. Sometimes the location changes. Sometimes as your career progresses, you're going to gain or lose different mentors. Same thing as when you made the transition from undergrad into medical school. You might keep in touch with some, but other mentors are not going to necessarily move with you. Location can affect the ability to close-knitness. Now, I will say with Zoom and everything, that is less of an issue, but sometimes that is. Some mentorship or mentor-mentee relationships will dissolve after a goal's been achieved. So maybe you're using them to match into a residency. And once you achieve that, you'll maybe keep in touch, but the relationship becomes less of a formal mentor-mentee. And then unfortunately, there are other mentor-mentee relationships where you grow apart, or some of them self-destruct, or they just kind of fade away because sometimes it's because the mentor or the mentee is not getting what they want out of that relationship, and that is okay. That just leaves you an opportunity to go find other mentors, because there's lots of them. Regardless of how a mentorship changes or how long it lasts, I just always want to keep everyone in mind, just always be thankful for the people who are helping you get to where you want to go. It always, I think, feels great to see a trainee succeed and have, know that you helped play a part in that. But a little thank you is absolutely huge. So how do you find a mentor? The short answer, ask. You have to kind of take it up, and whether it's sending an email saying you're looking for a formal mentor, or going up to someone at a meeting, but start with just engaging with a conversation or things like that. You can be very, very casual. Come to meetings. That's how I started and met a lot of people within the society. That's how I was introduced to people like within my program. Sometimes it's, like I said, as simple as sending an email, and then there are formal mentorship programs. So when you're interviewing for residencies, do they have a formal mentorship program for their junior residents where they pair you with a faculty or a senior resident or something like that? Um, you know, uh, this is where I'm going to put our plug in for MVSS. So we have, as part of our upcoming regional meeting that's taking place in September, we have this mentorship program. So when you sign up, it will ask if you want to participate in this. And that's actually something that I participated in when I was a trainee not so long ago. So I think this is great, and this is my plug for that. So that's all I have. Anybody have any questions?
Thank you for that. I think we'll open it up for the group to ask the panelist if anybody has any questions for us specifically. If you want to raise your hand, we can, or
So,
put it in the chat box.
Yeah, so if you go to the QA, I think all the students have access to the Q&A. If you want to put your questions over there, that would be great. I'll start, and I guess my question for Ashley is so general surgery versus 0 and 5. Correct me if I'm wrong, but I thought if you do a 0 and 5 vascular surgery residency, you can do a fellowship in cardiothoracic. Is that true?
I think there are two programs in particular right now that have cardiothoracic fellowships available to them, one of which is even built in Pennsylvania. But that is, I think, a newer thing. I don't know the exact number, but I do know there's 2 or 3 that are kind of going towards that direction.
So I think that's a career path people can think of if they want to do vascular fellowship, vascular surgery, and they between vascular surgery and cardiothoracic surgery. I think that's a nice nice pathway to do a vascular surgery residency followed by a cardiac fellowship. I think you become a complete aortic surgeon, and if that's the case. The only problem with that is finding a job. There's not that many jobs out there for a vascular/cardiac surgeon. I'm board certified in both, but I find it very, when I get out, there is no structure to encompass you in that. So you end up picking one path or the other, more one path than the other. I'm going to knock on you a little bit, Abby. From Alice Azim, what advice do you have for integrated vascular hopefuls that are not particularly passionate about research and feel more clinically oriented? Is it wise to apply to integrated programs with only a couple research projects? Abby, do you want to answer that? I'm going to click on you.
I don't know that I really can. I'm a 5+2, and we don't at MCW don't yet have a integrated program. I can speak from a general surgery, as I was not super research oriented. I'm more interested in education, but there's research to be done in education. I mean, a lot of what Ashley presented, those the graphs and things and comparing the programs, that's education stuff. So you don't have to necessarily think basic science research. So I think the realm of surgery, it's opening your mind to what you can research, and the quick answer to that is you can research anything that you do on a day-to-day basis.
I would kind of second her opinion. We do have the integrated residency, and we do not just look at the number of publications that you have. At the end of the day, we want to train somebody that will be a good surgeon, and we want somebody that's also clinically competent. So it's not the only thing that we're looking at. We're looking at your letters of recommendations. We're looking that you did multiple away rotations, that you're somebody that we think would be fit in well with our program, that you work well with the team. It's not all just your research numbers that we're looking at. Obviously, we want you to be clinically and academically interested and have interest in that, especially since we do have 2 years of required research. But that's not the only thing that we're looking at, because we know that you're coming into this and you did 4 years of medical school and you might not have 10 publications unless you have a PhD or an MBA or something else behind your name. So I would not shy away purely based off of your research numbers. I would encourage you to kind of shine yourself in like a clinical realm, do an away rotation, make sure your letters are really good, really try to get yourself involved in the meetings, meet people, do things along those lines. But at the end of the day, we need good surgeons, not just good academicians at the end of the day. So if you just want to be a good surgeon, that's still a great job.
Would agree with that as well. I think that the thing that I would like to kind of note for everyone, if you're really seriously considering applying for an integrated, is to understand that vascular surgery is really quite a small field. So that, you know, away rotations become pretty important. And the letters that you get are very important, because a stellar letter from, you know, like a Ben Starnes or something like that goes a very long way. So, you know, just to note that like there are other aspects of the application that are, you know, really, really critical.
Jason, do you want to take the next question? How do you manage your clinic, and how much time do you spend with your family?
Yeah, I was about to do that in the chat. So I do 1 day of clinic a week, and I operate 3 days a week. I have a basic science lab, and I am also doing research. So I have about 1 day a week to a day and a half a week of research time built in as well. I think most of us, especially in the Midwest, will do an outreach clinic as well. And so that's usually half a day to a day once a month. And it's kind of nice because you're not on site. You can't be called. You can't rush in to help anybody. You get to sort of check out for the day. And so I do one of those once a month. And then in terms of spending the amount of time with family, I think I spend plenty of time with them, and they feel the same way. Again, that's sort of an individual thing. I spent 7 days with them on vacation last week, and I think I'm good through March. That's sort of different for everybody.
I would say I have a very similar schedule. I have 1 to 2 days of clinic a week and 3 days of operating. I think most people that are in this are going to have some form of realm in that general vicinity. Going to the next question, I am going to pick on Loy for this one. Is there a disadvantage for older medical students, graduates around 35 to match into general surgery versus vascular surgery?
The answer to that is we're honestly, we're not allowed to discriminate against age, right? And we don't ask what your age is during the interview or during the interview process. So it depends on how much you want to do it and what you want to do with your life. If you're passionate about vascular or general surgery, that's fine. I have one of my residents that just matched into vascular surgery, did a JD diploma, worked for 2 years, and then came back and did general surgery, and now she's going to Yale next year for vascular surgery with 2 kids. She's just a phenomenal person. I don't think you should look at age as something that is going to guide what you want to do. Just look at life as a path and enjoy it. The goal is to enjoy traveling the boat, and enjoy everybody on that road with you. I don't know, anybody else want to chime in on that?
The integrated is probably a little bit quicker of a path. That would be the only advantage to going. If you said, I know I want to do vascular surgery, that's what I want to do. The only advantage would be it's a shorter training pathway, generally speaking, is kind of the only reason that I would bring that up in that aspect, would be that it is, if you're looking at time, it is 2 years less generally of clinical training. So. And then
just add though that, I would say being older is not necessarily always a negative. I think there's a lot of sort of maturation that comes with time and the ability to triage and, manage competing, emergencies that I think is very beneficial. And so, not to be a plug for an MD PhD, but I think the advantage of MD PhD is also being older, and I don't think places have discriminated based on the PhD, though, depending on who you are, some do threaten that is a negative.
I'll go back to my life stories. As I spent 10 years after medical school just get trained. That just took a longer way to do it. I'm very happy that I did that. This took me time to figure out what I want to do. I think this is
I
important.
wanted to jump to this question and make sure that the panel all answers this, but how did you know vascular surgery was for you? It's one of my favorite questions because I think it's a hard question to answer. I personally tell my medical students, deciding first of all whether surgical specialties are for you, I think is the first step in eliminating maybe half of your, clerkships. But I say go into each clerkship getting whatever you can out of it. Even if you don't go into surgery, that's the last time you're going to see surgery. Vascular surgery can be really hard, and I always applaud the medical students who know that that's what they want, because I certainly wasn't one of those. I figured it out about my third year of my general surgery residency. The patients are very complex, the procedures are long, but it's incredibly rewarding. And so I think when you look at the long-term relationships you get to make with your patients, which is very unique to vascular surgery compared to other surgical specialties, as Jason talked about, I mean, we are their primary doctors for all cardiovascular disease, and we happen to operate and do procedures, and we can, you develop great relationships with your patients. So that was part of what drew me to vascular surgery. I don't know if other panelists want to.
This is one of my favorite questions as well. I think that honestly, vascular surgery to me, having not even wanted to pursue surgery as an MD PhD, being destined for medicine, I thought, I just fell in love with just about everything about it. And, it became very clear very, easily that I was going to change my life plans. But basically, I love the creativity of it. I love the ability to be able to think about these operations, to have, an array of options that, you could potentially use to treat the patient. And then you're considering, their clinical history into making that decision. You're considering their anatomy into making that decision. You're considering all these things. And you're also actually, even with the longitudinal relationships, not only is that just great that you know them, it really is, but it's also great because you're also thinking about what you're going to do now for them and preparing yourself for what you're going to do in the future for them. And that is just an amazing thing. And, I tell a lot of my leg patients, my goal is to keep you having a leg as long as possible. And so we're going to try and do this now, and then we'll, potentially change strategies if that doesn't, and we're going to go from there.
Okay, let's look at the last few questions that we have. One was, as an M2, what opportunities in vascular surgery can you pursue outside of my own institute to set yourself apart? I would say the two things I would add, and then I'll hand it off to the other people, would be doing away rotations and then also going to these meetings. Going to the meetings that we have for MVSS, introducing yourself to people would be kind of some ways that you could set yourself apart. And then I'll hand it off to Catherine.
So, do you want me to answer that same question, or I don't know if I have a great, outside of your institution. I think that you can certainly, make contact with people at the vascular surgery meetings. There are student programs at many of the meetings. At VAM, they have a travel award. At MVSS, they have a travel award, and there are skills sessions that go along with that. And so you can apply for that as an M2, and I think that's a good way to be able to get exposed to other things outside of your institution. That would be my biggest recommendation.
So I'm going to jump off of that and answer one of the other questions. Somebody's asking if they're interested in pursuing an integrated residency, are away rotations at programs that only have fellowships a waste of time? I would say no, as an institution that currently does not have, a 0-5, but we have a very active IR division, and our vascular division is incredibly busy. And, my female partner, Kelly Brown, was the former president of MVSS. Again, you talk about who knows who, a letter from somebody like that is going to, go really far. So for me as a medical student, I came from a medical school that didn't have a big name, didn't have big name people. So I did a lot of away rotations and got letters from those because those letters carried more weight. The downside to that is that you're doing a 1-month interview. Like, so you got to show up to work, and you got to show up and put your best foot forward, because you're going to leave a lasting impression, for better or worse.
I think that's, I'm gonna try to stay on time. I know there's a lot more questions to answer. But hopefully if you come and join us at our yearly conference in September, you can have a one-to-one conversation, and there is sponsorships, and we do sponsor people and give awards if you apply for it. So there's some money involved if you want to apply for that. We're gonna take a 2-minute break.